So the main thing that we are interested in my lab is trying to understand what it is about people's brains that explains what kind of disorder they might have, psychiatric disorder, what makes them better in terms of treatment response, and how we can use information about their brain to design new. So everything we do inherently is biological. We eventually do have to talk about the brain, but we get there by trying to understand how people process certain types of information. The relation to Freud is not necessarily a direct or required one, but Freud was an originator in a way of emotion-related neuroscience. That is, back when he was starting, he had tried to come up with a biological way to understand people's emotions and emotional biases. That's what we're trying to do now with the scanner. And so if you take some of his ideas and you advance time and bring forward all the new and interesting things we've learned about the brain, I think you actually learn a number of important lessons that apply to the way we do our research. For example, we understand that a lot of what happens now that's important, that maintains your ability to function in life, happens unconsciously. Whether you call it something that Freud called an unconscious or not, that's a matter of debate. But most of the time, your brain is working to keep you functioning without you needing to be aware of it. In fact, you can make the analogy to riding a bike. If you were trying to learn to ride a bike and thinking about riding a bike, and you paid too much attention to it, you actually would perform worse than if you let yourself do it almost on instinct. And it's the same way with how we regulate emotions. What Freud argued is that a lot of how we process information and how we act on it and how we regulate it happens unconsciously. In his mind, a lot of that motivation, a lot of the processing was motivated. That is, if you had a certain type of bias for whatever reason, you'd be more likely to process information in a certain way. That is broadly congruent with how we understand a lot of emotional processing now. A lot of what he also talked about were what he called defenses. Defenses are, in a way that we regulate emotion. That is, some people regulate it in one way, and other people regulate it another way. And it could be adaptive or maladaptive. The way we've begun to now understand emotion regulation through work in my lab and other labs is as a set of automatic routines that the brain is running that continually help shape your behavior, your emotion behavior, the way you regulate emotion to be adaptive for that context, which is in some ways much like what he was arguing for. The specifics differ, and some of those specifics are important, some are not important actually, but I think that the heuristic that a lot of what we do is non-conscious holds to this day. What we do in the lab is we use MRI, something called functional MRI, which lets us look at how the brain is working from moment to moment. We take pictures of the brain in action. And we use that to understand a couple of basic things. First of all, how do people process emotion and how do they regulate emotion? What are the things that our brain does to keep our emotions stable and operating towards some goal that we're trying to reach at that moment? By analogy then, how does that go awry in psychiatric disorders? We study patients with anxiety, depression, and post-traumatic stress, a broad range of emotional disorders, and try to see how the brain systems that underlie healthy emotion regulation go awry in these patients. We then extend that another level to treatment. We look at various current treatments, for example, psychotherapy, medication, and brain stimulation treatment, things that we know work, and try to ask the question of why is it that they work? What's going on in the brain that leads somebody to respond or not to respond? That gives us the potential before long of being able to personalize the interventions. That is, should you get psychotherapy? Should you get medication? Should you get brain stimulation? We currently don't really have a way of guiding therapies based on anything, and I think the brain is going to give us an answer, at least in that regard. May not be the final answer, may not be something that we can yet generalize, but we don't really even have the kernel of understanding that's firm enough to ground the next science on. And then the other thing that we do that we're very excited about is try to use the information about this brain circuitry to guide new treatments. So we do new treatments in a couple of different ways. We've developed an approach of brain training that is getting your brain to basically go to the gym to work out certain capacities. The capacities to focus, to think, something called executive functioning, ability to manipulate information, inhibit responding to distractors, maintain information in mind, and ability to decrease emotional reactivity to negative stimuli. So people with anxiety or depression, they tend to react more to negative information, even non-consciously. And so we're trying to train that away. And the way we do that is with computer exercises. What people do is at home, they do these exercises over and over daily for about a month, and over that time begin to strengthen those capacities. As they strengthen those capacities, they're better able to deal with emotional contexts in life, and their symptoms start to get better. And the final thing that we do is we've developed, we've been working on a way to stimulate the brain non-invasively, guided by the imaging data. So when you see a region that's turned on too much or not turned on enough, you can manipulate that externally to some degree with brain stimulation and help that person do what their brain couldn't do on its own. So inherently in every study that we do, we compare patients to non-patients. But really importantly, actually, we compare different types of patients to each other. One of the things that we've learned now for 7-8 years since we started looking at this is that we make the assumption that a diagnostic category in the way we handle them in psychiatry isn't an entity, it's a thing. But actually you learn more by casting the net wide, which is why we do what we do in the lab. That is that a lot of patients will look similar to each other when they have different diagnoses, occasionally different from each other when they have the same diagnosis. And the important part there is that we ground it in the brain. Rather than looking at just symptoms, what people report, which has its strengths, but also has its limitations, if you look at the brain, you understand the mechanisms that explain why one person is another one way and one person is another, regardless of what their actual diagnosis is. Yeah, so one of the things that was very interesting about Freud and Freud's history, if you have to remember sort of the context, the neuroscience context in which it was happening, is that he was really trying to institute a neuroscience of emotion. And at the time, in fact, for decades and decades afterwards, that science didn't exist. So if you think about what we understood about neuroscience at the time that he was doing his work, we're only starting to understand something called the neuron doctrine. So the neuron doctrine is a very simple idea that we take for granted now. And what that says is that neurons are distinct units, cells, that are connected to each other through synapses in the brain, and not one cell directly physically connected to every other cell in what's called a syncytium. That is, the brain isn't one giant electrical organ, it's a bunch of little tiny units, brain cells, that connect to each other and communicate with each other, and that is the basic component of the brain, and then there's many, many, many types of neurons. So that was only beginning to be understood, and that's a very, very basic bit of information about the brain, which was new and exciting at the time. In fact, I think it was in 1906 that the Nobel Prize was given for that very idea. And that was really at the right time for Freud to come into this. So if you think about what the intellectual environment that Freud was in, on the one hand, there wasn't a psychiatry, there wasn't a way to understand and categorize these patients with mental illnesses. There wasn't even a way to parse them. On the other hand, there wasn't really a neuroscience. There was vague ideas about what the brain did, but in very, very general terms, we had no idea about neurophysiology. Nobody had recorded the activity of brain cells, and yet he comes in here and posits that there's a way to understand emotion, which is something we don't even understand that well now by understanding the brain. A very challenging set of ideas for the time, and certainly a challenging set of ideas for many decades thereafter. I don't know about profit, but he was certainly somebody who's interested in pushing boundaries. And I think that held in how he did a lot of what he did in general. But it also, if you sort of think about what that time was, there was a lot of revolutions going on, intellectual revolutions going on in the time. And so he fit well into that tradition, that context of challenging what we understood. Because because we understood so little at that time. It's so hard to fathom not understanding these basic aspects of neurobiology that we've understood for decades, but at the time were brand new, tools that were brand new that he was trying to make use of and saw the limitations of. So he came up with a lot of things, right? Some things were more right, some things were more wrong. Again, you have to contextualize the tools that he had to even evaluate these things. The basic tenets that he later came up with, that is that essentially emotional life is mainly unconscious. That heuristic holds to this day and governs a lot of what we do in our experiments. There's a lot of methods that have developed over the years that have helped operationalize that, ways that he didn't really have. The science at the time just wasn't advanced enough to even operationalize these things. So to ask, how do you even measure these things? He certainly had a better sense of what the big picture questions were than most people at his time. And that vision, if he had the tools, would have allowed him to do a lot more. So if he were in the lab now, boy, he would have a lot of fun. But that's scientific progress. Somebody has to come up with the idea and be ahead of his time on the idea, even if his methods are nowhere near useful to answer the questions that he wants to pose, and just throw it out there and challenge people to continue to think about it. In fact, the tradition in neuroscience and in behavioral science since the days of Freud have almost been reactions to Freud and all of the things that he then spawned, and then reactions to the reactions and reactions to the reactions, and so on and so forth until we are where we are. That's an iterative process where we build on knowledge. But I think in building you have to acknowledge what the initial foundations were. And there were really just a handful of people in the late 1800s and early 1900s that drove our understanding of psychology, understanding of neuroscience, whose impact in fact would be only realized later on. And Freud was one of those key players. So if you think about the context of the late 1800s and early 1900s, when Freud really did his formative thinking and his formative work, and he was really struggling, in fact, with the ideas that he was trying to bridge, you come up with an understanding of how visionary he was in terms of the kinds of questions that you'd want to ask, independent of whether the tools are there. What are the big questions? What are the interesting things that we want to explain about people? At the time, we're only beginning to develop an understanding of what the brain even is, this organ that you can see is important clearly for thought and emotion, but nobody had any idea how. And he, in his ideas, independent of the methods and the particular science he was able to prove, the ideas themselves were far ahead of their time. And that's what led to one thing after another happening that led to where we are now. That is, the traditions that developed in response to Freud and the ideas that he spawned, then spawned other things that were in reaction to those ideas. So behavioralism, for example, which came after psychoanalysis and psychodynamic theories. Behavioralism said the brain's not important. What we can understand is what goes into the animal, what comes out of the animal, input, output. And through that stimulus response, we're able to explain everything the animal does. You can explain some things that animals do for sure with those, and those methods are very strong in neuroscience now. But the idea of what happens between the ears, what happens especially in the human mind, got lost in that. And it's in reaction to that that we then had cognitive science developed, and then more advanced neuroscience approaches. And then if you take that big picture of what happened in the past 100 years, 120 years since Freud began, we're in a way back to where he started. That is, we're trying to understand motivated behavior on all sorts of fronts. We're trying to understand motivated behavior for decision making. How do you use your gut, if you will, to make decisions? Of course, you're not actually using your gut, you're using parts of your brain that you're not aware of. That's why it seems like a gut. How do you make emotional decisions? How do you regulate emotion? How do you react to things in your environment that are relevant to you, that are idiosyncratic? How do you function in life with all of these biases and control systems in play? That's essentially what Freud was talking about, especially in the early days. the ideas that Freud came up with in terms of drives and motivations, without having any idea of the brain substrates that define them, basically started to define what we call the limbic system now, which is parts of the brain that are very primitive, that you see in all sorts of lower animals, in much the same ways that you see in people, that drives our behavior in very, very clear ways that, quite frankly, are very adaptive. You want to have a long, stable fear memory of something you need to avoid. You want to be able to go after repetitive pleasures for however you might quantify that pleasure, things that might give you sustenance, for example, and be represented at that very basic level. All of those things exist in their rudimentary forms in the brains of lower animals as well as in us, and we can look at that neuroscience, that emotion or affective neuroscience, and relate it to some of his early ideas. So, yes, I think we just have to be a little careful with what we mean about confirmation. So Freud is a figure who brings controversy for various reasons. So in thinking about confirmation, there's ideas that he proposed that were much more sophisticated now in trying to think about an answer. Does that mean we've confirmed them or not confirmed them? I think you have to generalize a bit because he did live 100 years ago. He didn't exactly have hypothesized in mind everything that we can do now and what we can test. So with that caveat, what have we confirmed? We confirmed that a lot of how you process emotion, how regions like the amygdala, which is a core emotion processing region in the brain, a lot of how they react is non-conscious. That you can show people pictures that they have no awareness of whatsoever, and they'll respond in fairly characteristic ways. So you can show people pictures who have an anxiety disorder, let's say, and they'll respond with greater activation in this structure that processes emotion than people who are healthy. You can even show the people who will go on to develop post-traumatic stress disorder, for example, after a trauma, already have these biases in place in how their amygdala reacts to emotional stimuli. You can show that people regulate emotion non-consciously. That's something that we've done, for example, in my lab, is we found a way to see how people are regulating moment-to-moment emotional processing in ways that you can ask them about, they have no clue, and they'll happily tell you an answer that doesn't actually reflect what's going on. They're confabulating because they're doing this automatically. There's a part of their brain that's there to keep their performance on track, to help them regulate emotion in a way that they don't have to get involved. Once emotion gets of a certain sort, you might then want to involve cognitive resources, but most of the time you want to keep things relatively under the hood, operational without needing a lot of attention. All of those are ideas, in a way, confirming what Freud has argued. The specifics differ, but that's, in my mind, less important than the big picture. What were the kinds of ideas that he was going after, especially early on, where he was just formulating what are the questions that we want to address? And I think we've started to address a lot of those in a way that he would be pretty happy with, I'd imagine. So what we've, I'd say, largely confirmed that Freud had argued from the beginning is that our behavior is motivated by basic drives. Now, the way he characterized drives was maybe slightly differently than we characterize them now with neurobiology. But the fundamental point is that our behavior is motivated. There used to be this idea, for example, that you can make decisions in a decision-making task or context that are purely quantitative. That is, you weigh the costs and benefits in some sort of arbitrary, non-emotional way. But over the past 20 years, we've found out that that's really not true. In fact, probably the best decisions are those that incorporate emotion. But they incorporate emotion without you ever having to be aware of it. In fact, maybe even the best decisions, the best processes to make decisions are those that involve emotion that's not conscious. And that essentially is what Freud was arguing for, that behavior of any sort is motivated. It's motivated because it reflects yourself, that is your interests, your history. You know, I have particular things that I've encoded in my brain because those are my experiences, my historical past. Your immediate needs. What is it that I'm lacking right now on a basic drive level? All of those things, those basic drives are very much the heart of neuroscience now. In fact, if you look at any of the major journals, you'll start seeing things that if you abstract them just a little bit and you contextualize them in what Freud had in his mind then and the tools that he had access then compared to what we have now, I think they would be very consistent. That basic behavior is something we can understand in biological terms as individualized, as motivated, and as subject to regulation, all of which can happen non-consciously, and that problems in any one of those steps can lead to what we'd consider now psychiatric disorders. That is that as we describe normal behavior, you can imagine taking this bit out, taking that bit out, and impairing it. Just let's say along this chain, this little part is suddenly, for whatever reason, problematic. What happens as a consequence? That is essentially how we now think of a lot of psychiatric disorders, especially in the affective or mood and anxiety range. So people with depression, people with anxiety, people with post-traumatic stress disorder, they misprocess information in a characteristic way that relates to those basic drives. That's essentially the point that he was trying to make. Over his lifetime, he elaborated more and more on the psychological side of these theories. But he did that because he wasn't able to leverage biological tools. Ultimately, I think of Freud as a neurobiologist who got tried and got disappointed with the tools at the time as well as he should have. We have advanced tremendously in the 100 years since. And then he took whatever he had available. He had the psychology available, which is then what has dominated psychiatry for many decades afterwards. Because even now, the biological tools are research tools, they're not clinical tools. Yes, but medication I don't consider to be neurobiology in the same way as understanding emotional processing, cognitive processing is. A lot of the way medications have been developed is almost with the assumption that you have receptors that the medication will bind to that almost don't really matter where they are in the brain, that they exert a certain effect on behavior, and whether they're in one place or another in the brain doesn't really matter. In a crude way. Of course it matters, but when you develop these drugs, you actually develop them in a dish where you look at cells in a dish that have particular receptors and see how strongly these drugs bind, and then you give these drugs to animals and test the effects. At no point in that development do you use the understanding of brain circuitry, specific brain circuits that then also have particular brain receptors in particular places to guide development of these drugs. In fact, I think the history of recent drug development has been effectively that. That is that there are a lot of Me Too type drugs. That is, drugs that essentially copy the mechanisms of existing drugs, where we have not used the neuroscience to drive novel drug creation. We simply create drugs with fewer side effects or that hit 2 receptors instead of 1 receptor or what have you, and are basically flavors of the same thing that we've had for decades. Almost every single drug we have, in fact, I'd say every drug that we have in psychiatry, was discovered by accident, by people paying attention, by people seeing what are the effects of this compound, but not going after something because they knew that it was important for some effect. In fact, unfortunately, a lot of the current drugs that have been tried, new drugs for new mechanisms, have failed. And that leads us to test some of our assumptions about certain types of brain mechanisms important in certain types of disorders. But every major psychiatric drug, antidepressants, antipsychotics, were essentially discovered by accident. I think what we're looking at now with how neuroscience has advanced and the kind of nuance with which we understand cognitive neuroscience and affective neuroscience, and particular brain circuits, is at the point where we can start to think about the nuance of disorders. That is a disorder one homogeneous thing, or do we need to understand each person for what they are biologically? Do we design drugs that do one thing to everybody, or do we try to design drugs that do certain things to certain circuits? Do we stimulate circuits in other ways, by talking to people, by having people do computer games the train capacities? Do we stimulate those circuits such that we're now able to have a much more neuroscience-directed approach to any of this new therapeutic development potential? Or do we just rely on what we have done forever, which is let's just throw it out there and see what happens by chance? And I think that's an exciting possibility that we have in the field. No, we've never looked at that kind of either process or therapy. Our approach has been a bit different. That is, try to constrain as much as possible the kinds of things going on in therapy, because therapy already is very complicated, and try to understand a piece of it. So we have, for example, right now in the lab, is a study looking at exposure therapy. Exposure therapy, in this case for post-traumatic stress disorder, involves exposing the person to memories or reminders in the environment of the things that were either associated with the trauma or that induce a lot of emotion that they try to avoid. So somebody who has been raped, for example, might retell the story of the rape in detail and be able to effectively master their emotion, the anxiety they experience, by retelling that story over and over and over to the point where they're now better able to regulate their emotional responses and don't have that response to the trauma and to the reminders of the trauma. So it's a very narrow, specific kind of therapy. But the idea of exposure, that we in fact heuristically understand as a lay understanding, that if you fear something, you should confront it so you can get over it. That's essentially the idea of exposure. If you take that core idea of exposure and generalize it to things that happen in other kinds of psychotherapies, in fact, in any kind of psychotherapy, I think gives you a core understanding of a general process. That is, in almost every kind of psychotherapy, the therapist, whether it's psychoanalysis or cognitive therapy or more traditional exposure behavioral therapy, the therapist understands the patient well enough to know what it is that they either really don't like or really avoid or really drives them in negative ways. What they then encourage them to do is talk about it, think about it, expose yourself to it, to the point where you can now start to master it. In a psychodynamic or psychoanalytic therapy, you might actually not even say anything. You may let the person sit there and think about these things as you've just brought up some particularly emotionally intense memory or situation, and you have them sit there with it and try to interpret it and try to think about, how is it that I can manage this? And then you do that over and over and over. And I think of a lot of those things as essentially around the idea of exposure. That there's some way that you're teaching the brain to regulate emotion better through practice. And if you understand it in that way, there's a way to operationalize it with scientific tools, and there's potentially a way to enhance it, for example, with training the brain or doing psychotherapy in a different way or enhancing with certain types of medications, the basic process involved in exposure.
Technique.
It is. In my mind, it is a very similar technique.
My questions are out. You have to incorporate
right.
the question into that.
So, in a way, what I would argue for is a bit heretical with respect to theories of psychotherapy. A lot of therapies have been developed over decades with the idea that the particular mental content or particular thing that you do with the person is very important. But in reality, most of our studies show that almost every kind of therapy for most disorders has a very similar effect. So if it doesn't really matter what it is that you do with a person that gets them better in some unique way, that is, that you always have a much better response with one kind of treatment than another, then maybe there's some common factors to a lot of these treatments that is actually what is important. So there's a couple of things that come up. For example, the interaction with a therapist in the room. There's an important component to just feeling safe and listened to that relates to being able to even expose yourself to the ideas that and the fears that you might have. That's common across all types of therapies. There is the idea of just bringing out those most feared, most negative, most reviled things about yourself or some situation that's common to all sorts of therapies. And the way I see things from a brain perspective, we have to be able to understand things as basic brain processes. Those are basic brain processes. Social interactions, feeling of safety, exposing yourself to negative material, and learning to regulate that negative material. Now, how you get there differs between different kinds of therapies, but essentially, in my mind, they're doing a lot of the same thing. And, you know, one can even argue that the better outcomes with therapy come from the better allegiance your therapist has for some particular way that they could help you and really convince you of, and that it doesn't matter which technique they use, in as much as they're able to really get you to stick with it and get you to come back week after week and really have you challenge yourself. I think if there's any truism in therapies, if you sit there, you're not involved, and you don't challenge yourself, you don't confront all the negative material, you don't make any progress. So just basic biological mechanisms that you have to engage to be able to learn to regulate your own emotion. It's a big space to try to understand, but I think it can be simplified. And some of the ideas going back to Freud's original ideas would hold in terms of the kinds of brain processes that would. It's interesting when you think about what it is that people can do to change their lives. The idea of this positivity, you know, thinking positive psychology, to some degree might work for certain types of mostly healthy people. Once you get to the point of having an actual psychiatric disorder, that is, it really impairs your life, it's far from easy. In fact, I think the story is not, wow, look, that there are these things that you can just think positive and it changes your life, but is entirely the opposite. That is, that there's a huge population of people out there who are refractory or resistant to every kind of intervention we have. Those are the people actually that I think challenge our thinking, not so much the people who respond to just positive thinking. As a psychiatrist, as well as a neuroscientist, I face these folks all the time, as I see in my clinical practice and as I see in the lab. That there's a lot of people, especially with chronic depression, chronic post-traumatic stress disorder, chronic anxiety, who you throw medications at, no effect. Psychotherapy, good psychotherapy, no effect. That basically you run out of tools in the armamentarium to use on them, and they don't respond. People who for decades will have symptoms, and in a way you have to start thinking about managing their psychiatric disorder much like you manage a chronic disease, like hypertension or like diabetes. Psychiatric disorder, it leads to brain changes that are long-lasting, that even if you get better, for example in depression, and you go into remission, you get treated however you get treated, and things are going great, you're doing fine, your brain still shows the effects of having been depressed. There's a lot of things you can find in a depressed person, even when they're well, that will lead them likely to develop the next episode of depression. And so the story in psychiatry, I think, is how difficult it is to get people universally well. There's some people who respond well and some people who don't. That's what we're trying to understand now with these biological tools. But there still will be a lot of people left with chronic illness that we cannot get to go into remission. So I'd say, if anything, the challenge is not, why don't we just disseminate, positive psychology, and that could be such a transformative effect. The challenge is actually to understand these disorders as brain disorders, much like you understand disorder of the heart, a cardiovascular disease, as something impacting an organ. In this case, psychiatric disorders are disorders that impact the organ. The organ is the brain. The brain is experienced in a first-person sense psychologically. The brain can be measured in a third-person objective way, let's say with brain imaging. It's all the same organ in the end. So all of these things have to come together in the end. So there's a couple of, put it another way, it's an open question as to whether psychoanalysis works. And if it works, what does work really mean? So psychoanalysis is a particular form of treatment that differs from other kinds of treatments that we use in psychotherapy today, in that it's long-term. And the goal is not as much to decrease symptoms acutely, but to manage the chronic difficulties people have when they have a psychiatric disease, especially within a certain range that psychoanalysts tend to focus on. It's sort of a neurotic, anxiety, depression type range where people aren't psychotic, they're not bipolar, they have this chronic dysfunction in how they process information, how they react to it, and how they alter their behavior. So whether it works clinically, that needs to be shown in rigorous studies. So whether psychoanalysis works, I think you can answer empirically, and those, for the most part, those studies have not been done rigorously, but you can answer empirically. As you take certain people and you have them go through psychoanalysis and compare it to some other condition, maybe an education condition or a group interaction or something where you don't have the active components of psychoanalysis, and see whether that has a clinical effect. Certainly there's a lot of people who argue that it does have an effect, but for the most part, historically, psychoanalysts have not been interested in testing the efficacy of analysis and the mechanisms of analysis in the way that other types of therapy has. And that's partly just a historical tradition, and partly maybe some poor choices people have made over the years in driving that field. That has led psychoanalysis to be more marginalized. But if you actually look at what it is that people do in clinical practice, people don't do 12 to 16 week structured short-term therapies. The average time in therapy is something like 40 weeks in clinical practice in the community. And so what they're doing is maybe some cognitive therapy, some psychodynamic psychotherapy, sort of a mix of things. Depending on the person, might be one more than the other. But you manage the person's illness as a chronic thing, because most of these folks who come, they've tried other things. They've tried medication. Medication hasn't worked. Maybe they've tried other maybe they've tried other psychotherapies, and those haven't worked. And so what you're left with is a group of people who have a chronic disease and who you're trying to manage in whatever tools you have available. And some of those are psychodynamic psychotherapy tools. In fact, many therapists have to go through that kind of training. Certainly it's part of the requirements for psychiatry to go through that kind of training, as well as cognitive training, cognitive therapy training. So whether psychoanalysis works as it's packaged is an open question. Whether people use it seems to be more defined. People actually do use it a lot. But can you somehow make sense of all this and derive an understanding of the biology of this in a way to make it more powerful, more specific, validate the ideas even involved in it? That really needs to be done. It needs to be done directly, and has not been tremendously supported in the past from that community. But there's no reason that can't be done. No, for me to try to test a lot of these ideas, it's a little bit complicated. I think that if you think of what psychoanalysis is, and you think of it in more general terms, it might make some sense on how to get to an answer. That is, psychoanalysis isn't only a treatment, right? It's also a way of, it's a theory of functioning of that person, a theory of why it is that a certain person responds a certain way. Those can be tested biologically. In fact, those are being in many ways tested biologically now, and being put to the same kind of rigorous test that we put everything to. Whether psychoanalysis as a treatment based on those principles works, and there's many different types of psychoanalysis, that's a different issue. Whether the treatment works or not doesn't really have anything to say about the theory and the biological groundings of the theory. You can be completely wrong on the theory and the therapy could work really well, or you can have the theory perfectly down and everything psychologically reflect biological realities in the brain, and the therapy not be worth a dime. So they don't necessarily have to go together. And if you fail to find that psychoanalysis is particularly effective for a clinical population, doesn't mean that the theory is necessarily wrong. In fact, I think the history of psychotherapies in general has been one where theory and efficacy have, perhaps not by intention, been dissociated. That sometimes things work, but not for the reasons that you thought they would work. And sometimes things don't work, even though you had really great theories and things seemed right at the time. I think he was. I think Freud was a revolutionary in many ways. He challenged people to think about these big picture questions of emotional life in a way that they hadn't really thought about before. He challenged people to understand what we now basically understand to be psychiatric symptoms, but to try to understand it in a way that you can deconstruct it, that you can try to find causes, in fact, find causes that you can intervene with. That's what led him to his ideas about psychoanalysis as a treatment. But his real insight came from observing these people, making hypotheses, trying to test hypotheses, very much in the way that a scientist would now, except without all of the sophisticated methods and thinking that we have now. Nobody at the time came close to proposing theories, no matter what the available tools are, that challenged us decades beyond where the field was at the time. So as a psychiatrist and as a neuroscientist, I'm acutely aware of a basic fact. A basic fact is in fact something I'm sure that Freud was aware of at the time as well, which is that some people respond to your treatment and some people don't. Some of the people who respond to your treatment look the same in terms of how they present themselves as people who don't. So there must be something going on that explains why certain people respond and not other people. And that's very much something we're interested in the lab. We're taking these people, we're putting them through brain scans, trying to understand why somebody responds to psychotherapy, for example, why somebody might respond to medication. Trying to understand what it is about the way they regulate emotion, the way they respond to emotional stimuli, the way they regulate things that are not emotional, that leads them to respond one way or another. And the hope is, from both my clinician and scientist side, is that the answer that we come up with sounds something like this. That if you take the individual patient, you listen to what they're saying, not just for the content, but actually how they say it, the kinds of experiences they have, pair that with objective measures of the way they process information, you can come up with an answer for that person about what their likelihood of response is to drug A and therapy B and brain stimulation C, different options that you might have. The reason that this, to me, is very appealing, not only scientifically and clinically, it gives you better outcomes, but it actually leads us to something that Freud emphasized initially, which is what a lot of us have come into the field being motivated by, which is the individual patient. Listening and paying attention to the individual patient and what their problems are, whether you're looking at it subjectively by their report or objectively with tests of behavior, MRI, or what have you, that ultimately the answer comes in tailoring for that individual based on their problems. That's something that Freud was trying to do in the very early days, to understand what is their problem, how does that person differ from that person, and how do I do something with that information. And that's put in a different form where we're going now. In fact, as kind of an aside, I've recently taken over the neuroscience course for psychiatric residents at Stanford and reformulated it away from psychiatric diagnoses as entities that are valid in the outside world. That is, that depression is something distinct from anxiety, it's something distinct from schizophrenia in its entirety, and to something that tells a story about brain systems. That is, you have a brain system for fear, you have a brain system for attention, you have a brain system for reward, and those are perturbed in different ways across disorders. And those are perturbed in such a way that you also have a lot of overlap between individuals within a disorder and between disorders, defined traditionally. And the reason that they really like that course is even though it is just as neurobiological, the neurobiology now helps them relate to their patient. The reason they came to psychiatry is to listen to their patient and to do something for that patient, not for everybody within a diagnostic category. And as much as the biology starts to match the individual person, I think that will give you a better match not only for outcomes, but also from the psychological perspective, from the treatment, from the treater perspective, and from the patient perspective. I'd say his single greatest contribution is the basic idea.
My question now.
I think Freud's single greatest contribution is the basic idea that we can understand behavior that seems complex and messy and counterintuitive in terms of basic motivational properties of the world and of the person. But I think that if there's anything that we've learned through affective neuroscience, imaging of emotional processing, is that there are many factors that lead to how people are. But when people are challenged and they have particular biases that are their personality, that are the way that they kind of always process information, you can see that on an MRI scan. You can see their brain responses reflect biased information processing, biased emotional information processing. And that to change that, they have to undergo some process of learning, incorporating new experiences, internal or external. That process of learning, that is the basis of psychotherapy. The process of taking new information, using it to alter the way you process emotion, the way you process information biologically, that leads you then to change the way you'll react to new information.
So actually this works along, if I'm not mistaken, with the Freud psychoanalysis, because he says that you have to come up, you free associate, you go back to where it all started with your father, with your mother, with your whatever. And once you have reached that stage, you can start switching the switches.
Yes, so my perspective is one where the specific content that you process, is it that you're talking about your mother or you're talking about what have you, that's probably not the most important aspect of it. The most important aspect, my sense, is arousing emotion and learning to regulate it. Those are things we can understand biologically in a simple and clear way that we can put somebody in the scanner and even look at. What they're actually talking about may or may not really make a difference. But the important thing is that what they're talking about is relevant to them, and it evokes emotion. And it evokes emotion that they're having a hard time dealing with and regulating. And in doing that repeatedly, they can learn to regulate that emotion better, whatever its source is. So the process of getting there with psychoanalysis, probably very similar to the process of getting there in any kind of therapy. The difference being that psychoanalysis tends to take longer and be deeper and might get at other kinds of deep-seated emotions that you may not be able to get to in a 12-session cognitive therapy.
So what we need to do now is find the right pills that can imitate what you do in psychoanalysis. So
or
you put
enhance the
somebody
learning.
in psychoanalysis in the MRI, and you'd see what the changes of the switches are, and then you got the right pill to do it.
Yeah, so there's been a lot of interest recently in using medication to augment learning in psychotherapy, essentially the learning that allows you to overcome fear. Unfortunately, that seems to work better for some conditions than others. So for example, it works better for people who are afraid of heights, phobics in a sort of simpler way, people who have more of a social anxiety, who have difficulty speaking in front of a crowd, and less well for complicated anxieties such as post-traumatic stress disorder. But there's a huge amount of interest in taking our understanding of brain plasticity, the ability of the brain to change with experience and learning, which is the basis of psychotherapy, and enhance that. So now you don't need a year or however long to undergo therapy. You now boost the process and are able to do it faster and more effectively. We're not there yet, but there's a huge amount of work going on right now to try to get us there.